Hi, welcome. I know a few people in the room, but for those that don't know, my name's Carl Hennigan. I'm Professor of Evidence-Based Medicine and also Senior Tutor here at Kellogg College. The main event tonight is to welcome our next speaker, who is Director of the Uppsala Monitoring Centre. Well, actually, we're really lucky because we've got two directors of the Uppsala Monitoring Centre with us here. We have Professor Rafe Edwards, who was Director from 1990 to 2009. No, is that correct? That's right. And we have Professor Marie Lindquist, who is the current Director of the World Health Organization's Monitoring Centre in Adverse Events and Drugs. And I think that program's an international drug monitoring program, been carried out by UMC since 1978. It's an amazing program that keeps us safe and away from harms when it comes to medicine. So I think and we have an active collaboration with the centre, and it's my great pleasure to welcome our speaker, Marie Lindquist.
My younger sister, she could have been one of the thalidomide victims, a child born with badly deformed arms and legs. But she was lucky because my mother never took the drug. This drug was advertised as a wonder pill for pregnant women who suffer from morning sickness and sleeping difficulties. And it was said to be completely safe, according to the manufacturer, also in pregnant women. It wasn't safe, and many pregnant women took this drug in the late 50s and early 60s. And as a result, thousands of children were born with horrible malformations in more than 40 countries, including Sweden, where I come from, and also here in the UK. Some years later, when I was around 10 years old, I saw a very touching documentary series on Swedish television. It was called Peter and His Friends. It was part of a movement at that time to stop institutionalizing children and grown-ups with functional disabilities. And watching Peter, who was a thalidomide child, made me painfully aware that medicines not only do good, but also sometimes can cause serious and perhaps irreversible harm. Over the last 50 years in my lifetime, technology and medical science have progressed enormously. But such advances will not fully benefit humankind unless people can keep up with them, understand, accept, and manage both the opportunities and the risks. Professor Dame Anne McLaren was a very wise and distinguished woman and an enthusiast for promoting science in society. In a piece in The Independent in September 1994, previewing the British Association's annual Festival of Science at Loughborough University of Technology, that's a long word, she made an important observation that I would use as a foundation for this lecture. She wrote, "There is a growing realization that much of social science relies heavily on the backing of natural science. And much of natural science only makes sense in the context of social science." It's the second part of this observation that intrigues me in relation to patient safety. Much of natural science only makes sense in the context of social science. What does this mean for us? What insights can it lead us to in reducing harm to patients and increasing the benefits of therapy? What strategies might emerge from considering patient safety through the lens of social science? Let's begin this analysis in the Democratic Republic of Congo. In February, during a major outbreak of Ebola, Médecins Sans Frontières suspended all outreach and treatment activities. They had 2 clinics running in Katwa and Butembo in the North Kivu province, and they had been attacked. One center was burned to the ground. The safety of patients, communities, and medical staff was not just threatened, but obliterated overnight. Medical science is not the root cause of these events. Medical science cannot explain them. Medical science cannot bring recovery and healing. For an understanding of a community in a state of such destructive chaos, we must turn to politics, economics, sociology, social psychology, to a grasp of the effects of civil war, suspicion of outsiders, economic insecurity, deprived and neglected communities, to the realities and impact of poor or absent education and health systems. Resources poured into the area to combat Ebola bred resentment in people who had no access to normal healthcare, who had never heard of the disease, or who believed it was a political plot to undermine social stability. In this and in other comparable emergencies, like the polio vaccination crisis in Nigeria, we see not the failure of science, but the failure of empathy, of research and knowledge, of understanding, and of robust, collaborative, proactive, and sustained communications. But the weakened and hazy notion of communications hardly does justice to the case. The failures are in political and sociological analysis and humility, in arrogant assumptions by authorities that they know what needs to be done, and that they can ignore collaboration with communities when they take action. My scientific discipline, pharmacovigilance, deals with the detection and prevention of unwanted effects of medicines. Some of these effects stem from the medicine itself, caused by its active ingredients, but much of the harm suffered by patients taking medicines is a result of preventable mistakes and errors due to failures in how patients and professionals interpret, understand, and apply existing knowledge. Many patients, particularly the elderly and those with multiple illnesses taking a lot of medicines, some of which may interact and cause unintentional changes in effect. On top of this, we have a growing problem of antimicrobial resistance and quality issues ranging from the production of substandard to falsified and adulterated medicines. Professionals know these facts, but do they know how to mitigate and prevent them? And how do patients experience them? How well prepared are they for such complexities and risks? The destruction of Ebola facilities in Congo may seem a long way from these concerns, but it is not, because in both situations it's about the management of risk and how people are being harmed, and the need to go far beyond medical science and technology to understand the causes and find solutions. To achieve the aspirational vision of patient safety, we need to consider also the role of human factors and address psychological and behavioral aspects, as well as broader societal issues. Only then can we hope to have a real impact, reducing human suffering and improving people's health globally. Dealing with risk lies at the core of patient safety. The key message is that no human activity is absolutely safe or without some element of risk. This applies equally to medical care, which is amongst the most complex of human enterprises. Like science itself, medicine is full of uncertainty and unresolved questions, though often not understood or admitted, and patients find it disturbing. Any medical action, or indeed inaction, always carries some risk. The urge to create a safer world is sometimes expressed in the form of false hope that risk can be eliminated entirely. That this crisis, for example, will never happen again, as politicians and CEOs sometimes say. Or of the impossible demand for simple, unambiguous answers about complex and uncertain issues. Only if expectations are more realistic can anxiety medicine be averted. Anxiety does sometimes lead to crisis. Expecting too much leads to disappointment, frustration, and cynicism. To prevent such negative reactions, we need to have a discussion climate in which it's possible to have an open, honest debate and a balanced, nuanced assessment of both potential benefits and harms of available therapeutic options, on the individual level and for society as a whole. And this discussion cannot be held solely on the basis of data. A public discussion of these issues involves many challenges. First, Issues involving health and medical therapy are by nature complex and difficult to explain in plain language to people without some background in medical, scientific and technological domain knowledge. The role of professional medical media has traditionally been to report on new findings and hypotheses, and to provide a forum for scientific debate among experts. The general media has had the important task of explaining the results to the general public, and particularly in cases of controversy, to supply platforms for public debate about the implications of the new findings and how to translate evidence to policy. Sensationalist media have always existed, and papers need dramatic stories to sell, we know that. Science provides rich pickings for them. Now, with the uncontrolled growth of social media, impartial, balanced reporting risks drowning in a sea of speculation, misinformation, and sometimes outright lies, often driven by political or ideological agendas. The credibility of scientific publications has been damaged by fraud, conflicts of interest, commercial interference. The intermediary role of the mass media has been compromised by lack of journalistic experience and expertise, and uncritical reporting of even the most dubious pseudoscientific junk. Second, the knowledge base is not static. On the contrary, publication of new, modified, and often seemingly conflicting evidence is a more or less daily occurrence. Managing change and communicating uncertainty are both notoriously difficult, not the least when we are talking about matters of life and death. And how can we expect people to act rationally and make good decisions if, as is often the case, experts cannot agree between themselves or change their opinions year by year? When do we know enough to act? And how do we balance the need for prompt access to new, improved therapy against the duty to do no harm, or as little harm as possible? The trend in society towards increased polarization of opinions, I think, does not provide a fertile ground for reasonable argument or rational decision making. Third, the concept of evidence-based medicine rests largely on the use of data from clinical and observational population studies and statistical methods. Frequencies of outcome and statistical averages are important to quantify risk on the overall population level, but cannot be directly applied to provide optimal therapeutic and medical care to the individual. What is crucial to know for the treated patient is, will this treatment benefit me? Will I get an adverse effect? Do I trust my health professional to have the knowledge and the time to help me if I do? Are there any alternative treatments that I might want to consider? No amount of data will convince or convert a skeptic who has been exposed to a powerful anecdote or who doubts the credentials of the source. Fourth, we have to consider not only the inherent communication difficulties that I've already mentioned, but also that the discourse in many parts of the world has to take place in the context of extreme economic, environmental, societal, political, and security fragility. And how can we talk about rational and safe use of medicine in places where there is no clean water, not enough food for the children, and where medicines are either not available at all or not affordable for those who need them the most? How can we hope to engage millions of refugees and displaced persons? Fifth, even in countries that have enjoyed peaceful development and stable democracy for years, there is a widening of the gap between the haves and have-nots, and more polarized views and identities threatening social cohesiveness. Previously open societies are moving towards a climate of fear, where conspiracy theories spread, fake news and allegations of fake news are rife. Who takes responsibility for the survival of an honest dialogue and distribution of truthful messages in a world where progress is measured only in economic terms, and where demands for equity and fairness for all are replaced by calls for the strong leader who can protect us against them? At the best, assessment of benefits and risks and evidence-based decision-making are very difficult matters. There are no magic formulas that can be adapted to find answers, and there is definitely no one-size-fits-all solution. On top of that, risk perception is a very individual judgment based on personal preferences, biases, values, and needs. When do we have enough information to be able to make considered decisions? What is the knowledge we need about those for whom we are providing the information? Can we, in all conscience, continue to use the word safe at all? I'll now give a few examples to illustrate some of the communication challenges. Modern drug safety pharmacovigilance started about 60 years ago after the thalidomide disaster. It's easy to think that thalidomide would never be used again after what happened. But since it was later found that this substance has positive effects in the treatment of leprosy, myeloma, and some autoimmune disease, it has been used in many seriously ill patients with good results. So is all then well? Tragically not. In spite of rigorous safety restrictions and protocols in countries where thalidomide is registered for use, there are reports of new cases of babies born with phocomelia and other malformations connected to maternal thalidomide use. In Brazil, a country with thousands of new leprosy cases each year, thalidomide is used predominantly in communities with poor health education, high levels of illiteracy, and habits of widespread sharing of medicines. In a BBC report some years ago, Gilvan, a mother who took her husband's thalidomide pills, says, "The doctor didn't tell him that women couldn't take it. He said they didn't tell him anything about it. Her son has no arms or legs." WHO says that experience has shown that it is virtually impossible to develop and implement a foolproof surveillance mechanism to combat misuse of this drug, and does not recommend use of thalidomide in leprosy. But doctors and leprosy sufferers say that the drug is vital, believing the benefits outweigh the risks of harm. The Brazilian study reporting 100 cases of possible thalidomide malformations has also been contested. This is an ecological association, not a proven causation, says Diana Lockwood of the London School of Hygiene and Tropical Medicine. Association with thalidomide was not demonstrated. This statement reflects a common belief among epidemiologists that causation can be proved only statistically in control studies, when in fact what studies show is a statistical probability of a certain outcome being more frequent in the exposed population compared with the unexposed. The absence of a statistically significant result does not mean that the particular outcome will never occur. It may be improbable, but not impossible. And the generalizability of epidemiological studies depends on their size. Are there enough participants to be able to identify all possible undesirable outcomes? Mostly not at all. And how closely the study population resembles those who are going to be exposed in clinical practice. I mean, the exclusion criteria typically bar the most vulnerable patients from participating in the studies. But there is a demand for rapid access to new effective treatments, and this has become a global public health issue and a matter of political and scientific urgency. New medicines are desperately needed to treat major endemic diseases such as malaria, HIV/AIDS, and tuberculosis, not the least in the light of the growing global problem antimicrobial resistance, which has rendered many existing treatment options ineffectual. WHO statistics on malaria show that there were more than 400,000 deaths in 2017, 93% of them in Africa. So it's not so strange that the mothers my colleagues met in Malawi recently cried for help to protect their children, and they pleaded for rapid access to effective treatments. But before a new medicine can be released, it needs to be tested. Can we assume that the people of Malawi and other countries in urgent need of new treatments are prepared and able to let their young ones take part in clinical trials to ascertain that the new treatment is efficacious and safe enough for their population? Will they support the new options and the efforts to speed them along if they feel that they are being subjected to an experiment? How can we make vivid the reality of benefit and harm for a population for whom data is a foreign language? What is their view of the benefits of the new treatment and the risks? And if we go ahead with mass deployment, treating thousands, perhaps millions of children based on preliminary data, how do we ensure that the risks are understood and embraced, and that there are appropriate facilities and resources in place for active, local, ongoing safety monitoring as the drug is being used in the population? Perhaps the most challenging communication situation of all in the area of medicines concern vaccines, where the debate has become so polarized as to divide the world into those who are for or against vaccines. Dengue fever is an infection that is spreading across Asia and Latin America, with 500,000 severe cases requiring hospitalization per year. Of those, around 2.5% die, and that's 12,500 people. Less severe dengue has lower case fatality rates, around 1%. The first dengue vaccine, much anticipated, was licensed in 2015 and has now been approved by regulatory authorities in 20 countries. In July 2016, WHO issued a position paper which refers to a hypothesis raised in the clinical trial report that in seronegative children, that is those who had never had the infection before, the vaccine might act as a silent, natural infection that primes these children to experience a more severe secondary-like infection upon their first exposure to the virus. So in their recommendation, WHO concluded that use of the vaccine in populations in which natural infection is low is not recommended because of low efficacy and potential longer-term risks of severe dengue in vaccinated seronegative individuals. They further specifically stated that vaccine introduction must be accompanied by a targeted communication strategy. That sounds very easy, doesn't it? In the Philippines, one of the worst affected countries, 700,000 school children were vaccinated in the program that started in 2016. So they all had the dengue vaccine. But this program had to be suspended after there were several cases reported of fatal severe dengue in vaccinated children. Reference was made to the hypothesis raised earlier that seronegative children might be at higher risk of severe dengue after vaccination. A subsequent reanalysis of the data held by the vaccine manufacturer was requested to specifically analyze the difference between seronegative and seropositive children. And the new analysis supported the hypothesis that seronegative children might be at higher risk. And WHO subsequently, in December 2017, issued guidance that pre-vaccination screening is a recommended strategy, and that only persons with evidence of a past dengue infection should be vaccinated. By then, however, the damage was already done. Rumors of cover-ups of deaths and sinister use of Filipinos as guinea pigs had spread. And according to Professor Heidi Larsson, public concern turned to outrage, which was fueled by a highly politicized response after a recent change of government, with officials blaming each other. The ongoing Global Vaccine Confidence Index from the London School of Hygiene and Tropical Medicine reports that in 2015, 93% of Philippine respondents strongly agreed that vaccines were important. In 2018, that figure had fallen to just 32%. And only 1 in 5 people believed vaccines are safe. And there is no rational doubt that vaccines have brought enormous benefits to the human race, saving tens of millions of lives in recent decades and billions of pounds in healthcare and social costs. But this does not exclude the possibility that some vaccines, in rare cases, may cause considerable harm to susceptible individuals. And we must be able to talk about this. We need to identify who's at risk and why, and find ways of preventing the problems. I mean, the view that potential risks associated with vaccines should be discussed privately only by experts, because open disclosure might jeopardize the public trust in vaccination programs, I think is very likely to cause the very harm it's intended to avoid. I mean, there's nothing that gives better fuel to conspiracy theories than the notion, whether real or not, that issues are swept under the carpet, that there is, in fact, a conspiracy. Many so-called anti-vaxxers build their firmly held views on anecdotes and social media postings, on poorly considered claims, rumors, and sometimes completely false evidence and accusations. But it's not right to accuse all people who express concerns about the safety of vaccines to being irrational and emotional. I certainly see a strong emotional component also in the fervency with which vaccination campaigners put forward their uncompromising views that vaccines are safe, period. The strong contempt shown by both sides for each other's standpoints have made a reasoned and reasonable dialogue almost impossible. And cascading data just makes things worse. I mean, there's some evidence to suggest that the ostensible extreme polarization does not accurately represent reality, that there are cautious parents open to the influence of their trusted physicians, that between the extremes there may be a significant population of undecideds. If we alienate them with ill-considered character assassinations, that may be making things all too easy. So what needs to be done? Well, if I were to outline the problems and glibly propose better communications as a platitudinous solution to all our ills, I would be insulting you and failing in my duty as a scientist and thinker. I chose reform communication for the title of my talk, and I shall spend a few minutes describing the basis on which reform communications might emerge. Where can we start to find out what is needed? And can such an analysis help us see where our traditional modes of communication fail? I talked to my colleague and friend Bruce Hugman, who is an English scholar and a communications expert. He said there is no better place to start than Aristotle and the art of rhetoric. Rhetoric, in contrast to dialectic, Aristotle writes, is the faculty of observing in any given case the available means of persuasion. Nevertheless, persuasion that takes place before a public audience is not only a matter of arguments and proofs, but also of credibility and emotional attitudes. Logos, ethos, pathos. Logos, the meaning, weight, and logic of the message. Ethos, the credibility and good character of the communicator. Pathos, the emotional context, the discovery of shared values, the expression of genuine empathy. And subsidiary but essential, lexis, style. Aristotle is very good on style, counseling in Book 3, avoidance of language that is flat, banal, frigid, whatever its degree of clarity, at one end of the spectrum, and language that is complex, over-elaborate, or obscure at the other. He talks of the use of metaphor, fables, maxims, allusions, parallelism, repetition, and juxtaposition as essential means to persuasion. How about that? While there are some distinctions in rhetorical demands of the spoken and the written word, the core principles remain valid. There is much more, of course. This talk does great injustice to the intricacy of his arguments, but it provides us with some perspectives against which to review scientific, medical, and patient safety communications, all of which have a fundamental intention to influence. Persuasion to read them in the first place, to take them seriously, and process their content, to think or act in line with their intentions. For nearly 2.5 millennia, these principles have underpinned the most effective communications in all fields of human endeavor. They have been elaborated and refined in the modern age, but they remain central in their accuracy and persuasiveness, just like the ambulance sirens. So how do patient information leaflets, risk management plans, safety warnings and alerts, vaccination and other public health campaigns, and not least scientific and public media reports and social media accounts stand up in the light of Aristotelian wisdom. Did I get that right, Jeffrey? Logos is a message credible, clear and strong. Ethos is a source of the communication regarded favorably as credible and trustworthy. Pathos, does the communication take account of the true feelings and priorities of every member of the audience? And does it present itself in a way that creates and engages with emotions? Lexis, within the parameters of appropriate language for the audience, is the message attractive, engaging, memorable? Answers generally no, 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 and no. Lack of trust is key in any discussion about failures of communication. By this I mean doubts about the authority, credibility and honesty of the partner. For communication to be successful, it needs to be a two-way interaction, a dialogue, a partnership based on mutual knowledge, respect and trust. To influence people, persuasive skills are needed, but there is a fine line in fact and in perception between persuasion and manipulation, oppression and coercion. It's natural to respond with inertia, suspicion or even hostility if we perceive that we are being put under unnegotiable pressure to change, without our position being interrogated, without support or feeling that any benefits are offered. So it's not so strange then that there are frequent communication failures in healthcare, when much of what is referred to as communication is merely conveying a dictate from someone distant in authority, be it an organization or a person, requiring the recipient to pay attention, to act, but with no element of dialogue or debate, and with no investigation of the pre-existing context. And there's another profound communication issue that affects and commonly damages patient safety: the failure of institutional and corporate communications to provide safe and coherent management of patients through professional culture, human and efficient systems, information sharing and teamwork. This is from the Institute for Healthcare Improvement. If you want to ensure medication safety or the long-term success of any safety initiative, you need leadership, commitment, teamwork, good communication and reliable systems. You need psychological safety, accountability, the ability to negotiate, transparency and continuous learning. You need an improvement strategy as well as a measurement strategy. An example: the farm-to-farm model used in Hawaii addresses a growing problem of community-acquired medication harm among high-risk chronically ill patients. This model demonstrates the importance of deploying specially trained pharmacists in the hospital and in the community to systematically identify and resolve drug therapy problems. A BMJ commentary on the Hawaii scheme stated, "Changes are needed across the US healthcare system to assign the role of primary responsibility to a single clinician or a core group for each patient, and ensure the means for easily and effectively communicating what should be a deliberate process of starting, monitoring and discontinuing prescribed medications across multiple clinicians, caregivers and healthcare settings." What that characterization does not include is the fundamental necessity of communicators and caregivers being close to the communities they serve, so that they are known to and know about their constituents in intimate and personal detail. One of the Médecins Sans Frontières conclusions about the Congo troubles was that communities must be treated as partners in the response. We must listen to their needs, not preach to or coerce them. Those mild words camouflage a revolution in what communication means and what it must mean if patients and communities are to have the best chance of being safe. Planning effective communications means radical commitment to research, engagement and listening, a process that involves the wisdom and skills of social science long before a message is decided or formulated. Communication cannot work if it's delivered out of the blue from distant sources, It can work only in context of established relationships with trusted providers. If medical science is neither the first cause nor the potential remedy for the crisis in the Congo, it hardly needs to be said that regulatory science and bureaucratic intervention would be equally ineffective in transforming the situation. Something much more penetrative, robust, and engaging is required. In communication, the reforms are essentially in engagement with population and patients, in their immense variety and in their immense number of special, unique locations. More than 20 years ago, the Rhetoric Declaration set out the aspirational standards for effective communication in pharmacovigilance and patient safety, calling for vigorous, open, ethical, patient-centered values and methods. Its comprehensive vision remains as relevant and powerful as ever, even in a much-changed world. Reforming communications is a huge challenge in itself, but it is not enough. The radical insight is that real improvement in patient care and the achievement of patient safety requires systemic reform throughout the entire healthcare system. And this depends on a host of integrated reforms of relationships, systems, and institutions. Many of such reforms, of course, are contingent on highly sensitive, creative, and effective communications among multiple groups and players. Rapidly identifying and admitting error, welcoming critical opinions, even from the most junior ranks, are two emblematic reforms needed. And placing the welfare of patients above profit is another. Major change affecting a critical part of society is not possible without serious political will and commitment to develop and stick to a far-reaching and sustainable reform agenda. A commitment that must go far beyond MPs making vague promises during election campaigns. The message must be spread and accepted at the grassroots level that fundamental changes in the way in which healthcare works require both time, effort, and money. There is no quick fix. There is no easy remedy to societal ills. Change requires leadership. The strength of political leadership is often measured in terms of power, and not uncommonly executed through the capacity to rule people with ruthlessness, self-interest, and a sense of entitlement as driving forces. I'm talking about another kind of leadership, the determination and courage to stand up for a vision and to stand up for one's beliefs, even when they challenge the prevailing general opinions. But also the ability to bridge differences and to build true community spirit and cohesion. Good leadership recognizes that political and structural reforms will not solve the problems in society unless they are accompanied by cultural and behavioral changes. The World Health Organization has presented its transformation agenda for global health, where the Director General reports that WHO needs to become an organization that is fit for purpose in the 21st century. I believe these ambitions are honestly meant, but I can only speculate how far the outlined reforms will go in terms of transforming a giant bureaucracy and pushing healthcare reforms in the countries. However, I do think it's really important that the Director General, Dr. Tedros, has repeated the assurance WHO remains committed to continue supporting the Ministry of Health in the Democratic Republic of Congo to end the Ebola outbreak as quickly as possible. And this in spite of a new attack on the 19th of April on a hospital in which a WHO epidemiologist was killed, and some new indications that the situation is spiraling out of control. I just hope that all the people involved grasp the complexity of the challenge and realize that solutions will be found only when the deep social and cultural issues are penetrated and respectfully understood. I'm convinced that a better society is not created by systems. It's created by individuals, people, who work together to improve systems and themselves. Thomas Jordan, in his post-conventional manifesto towards the good society, proposes that we need to broaden our conception of what political activities are. Whereas conventional political strategies seek solutions in reforms of the external structures, the alternative approach would emphasize a continuous work with our internal structures, the nature of our values, attitudes, and interactions with each other. I can't even pretend to have answers to all the problems I've raised, but approaching the end of this talk, I will offer some personal recommendations as food for thought. Starting with ourselves, before we do anything else, we should examine our philosophical biases, the effectively emotive but hidden aspects of our personalities, our assumptions, our beliefs, our obsessions, all of which influence how we respond to the external world. We should question the arrogant assertion that what we do and say is rational and beyond question. Angela Phillips, in her recent talk against stupidity in the media, said that the very first step in the consideration of any new piece of information should be to stop and check your own preconceptions. Whatever one's worldview, if the evidence doesn't tell you what you thought it would, then you need to reconsider your own assumptions before rejecting the evidence. In meeting with those who disagree with us, we have to make more efforts to exercise empathy and to find common ground. Vaccine deniers are perhaps people with as much concern for their children as we are. What is it we share rather than what divides us? Scientists must be open about the motivation and reasons for their views and conclusions. There is no place for secrecy over results where patient safety is at risk. Scientists must admit that there always will be some degree of uncertainty about existing knowledge. Even established and credible truths are no more than probabilities, albeit some more plausible than others. We should be highly skeptical of p-values as gateways to knowledge. The scientific dialogue needs to be transparent and provide adequate and relevant explanation and interpretation to enable public understanding. Conflicts of interests are not just financial or academic. They are political and philosophical too, and those need to be admitted. Anyone who publishes on scientific matters has a responsibility to separate facts from opinion and to make any uncertainties apparent. They must always be ready for an open and healthy debate, and they should be prepared to change their minds when presented with convincing facts and arguments. We must insist that negative findings are published. Politicians and decision makers should demonstrate their commitment to saving patients from harm and make sure that there is adequate funding, competent and properly trained staff throughout the healthcare system, and the necessary equipment and facilities to do a good job. They must reduce bureaucracy as far as is compatible with good practice and provide a culture in which professionals can flourish and grow. They should ensure good, proportionate governance of all the activities and processes of scientific endeavor and regulation. And they should encourage and enable a climate of trust, not one of fear. In cases of conflict, they should seek synthesis, trying to bridge divisions rather than exacerbating them. Regulators should adopt a more flexible, responsive and agile approach to ensure that new effective medicines are made available for those who need them. But in moving away from the one-off marketing authorization towards conditional approval of new therapy, they must ensure that there is infrastructure, resources and competence in place for continuous, iterative safety monitoring and evaluation throughout the whole life cycle of medicine use. In this respect and others, regulators have a responsibility for much more proactive engagement with the public, especially in managing expectations and communicating the transitional nature of much knowledge in medicine. Pharmaceutical industry should set aside more of their profits to pay for development of medicines for neglected diseases and neglected patients. They should stop aggressive direct-to-consumer promotion, which does not give the public a realistic chance of assessing neither the potential benefits nor the risks of harm of the advertised medicine. They should not withhold information of potential harm, even if public release may be negative for their sales. The industry has a special responsibility in that it provides goods and services which are essential for the health and survival of the entire human population. And to support the development of innovative medicines, it's reasonable that they generate a very good profit. But any employee, be it the sales rep or the CEO, who is prepared to lie and cheat in his pursuit should be dismissed without pardon. It's not reasonable to put profit above human welfare. Public media and news corporations should reassess their mission. If they cannot maintain audiences without a fundamental commitment to an honest and realistic depiction of current evidence, they should make that clear and place themselves, without pretending otherwise, in the categories of entertainment or popular fiction. We might hope that they will consider carefully how best to inform segmented audiences, adapt their messages to different contexts, such as emergencies. We might dream that they should provide the facts and evidence needed to make good decisions on therapy and avoiding sensationalism. Particularly scientific dissent and uncertainty need to be examined and carefully explained. Simply presenting two opposing views just invites confusion in the public arena. I believe in freedom of speech, and I'm worried about the push for no platforming that excludes unpleasant voices from public spaces. But freedom of speech should not be used as an excuse for allowing people to get away unchallenged with unsubstantiated claims and unfounded accusations. Finally, doctors and other healthcare professionals should make sure that they regard and treat each patient as the unique individual they are, that they are alert to the immense complexity of every human being with their preferences, values, biases, and expectations, as well as all the characteristics that come from their life history, education, culture, and so on. No one should assume that the results of epidemiological studies are gospel that apply equally to all patients, nor that guidelines based on them are to be followed uncritically. Doctors and healthcare professionals should be honest in their communication with patients, seek dialogue, and be open both about the limitations of scientific evidence and their own knowledge. I mean, this sounds like platitudes, but in essence, it's a challenge to elicit the most acute and penetrating elements of human interaction. And doctors should demand working conditions that facilitate change and give them more time with each patient. I think I read yesterday in the paper that there was a push so that doctors would have 15 minutes instead of 10 minutes with each patient. Hooray. My conclusion is that reformed communication is not the sole answer to improve patient safety, but it is a vital starting point, and it provides a unique vision and bond that will inspire players in a cohesive effort to do a good job. It is my firm belief that scientific progress, and indeed the development of society as a whole, rely on open and constructive debate, a public discourse which must be based on mutual trust and respect for the viewpoint of others. Unless there is a genuine will to find a way forward, to resolve problems together, we shall see much more of the polarization that can only end in aggravation or cementation of existing problems. I mean, even if we strongly disagree with someone's opinion, we have the duty to listen and to try to understand their motivation and reasoning and to seek to resolve conflict. And we all have the duty to act, not just talk, and act to the best of our abilities, so that we make personal, tangible contributions in our daily life towards the systems in which we work and for the building of a better society. Only then can we turn aspirations into practical results and create real hope for the future. I'd like to finish with an example of how patients were saved from harm in the midst of an ongoing catastrophe. It's a story of hope, of human dedication and courage. and of deep understanding of the needs and perceptions of the people around us. Pharmacovigilance, medicine safety, during the Ebola crisis in Sierra Leone in 2014 meant not only the safety surveillance of experimental treatments, but also to try to survey products like disinfectants, rubber gloves, and other equipment that had to be used. Treatment of malaria, as well as pneumonia and diarrhea, became difficult due to reluctance to seek medical help. Many people feared that the similarity of the symptoms with Ebola would prevent them from returning home if they went into hospital. Therefore, the pharmacy board headed by Wiltshire Johnson argued that it was necessary to run an anti-malarial mass drug administration to treat malaria, and thereby moving some of the stress from the battleground of the Ebola outbreak to a different part of the health sector. So in collaboration with the National Malaria Control Programme, the Pharmacy Board's National Pharmacovigilance Centre actively participated in real-time safety monitoring. They went into the communities, they promoted effective treatment in the periphery, as well as searching for, identifying and managing adverse effects of the treatment. This really stretched their capacity to the limit, but it became a success. The subsequent data analysis of the data they collected led to changing the first-line treatment of malaria as a result of what they learned during this. When I asked Wiltshire what was the most difficult thing during this period, because I said to him it must have been horrible to be in the midst of all this, he said to me, I found it really hard to come home at night, and I wasn't able to touch my son and hug him because of the risk of transmitting Ebola. What we do in medicine touches the most precious aspects of people's lives. We have a duty to try to do better, to pursue the very best science, but also to reach beyond science into the social, spiritual, and philosophical worlds in which we and all human beings are immersed. There we will find many of the secrets that will help us all to live happier and safer lives. Thank you so much for listening.